Please join me in welcoming Shara Turul, and I'm going to give a brief bio introduction. So Shara graduated from UVM in 2013, educated and trained as a family nurse practitioner, and has chosen to focus her work in substance use disorder settings. As an RN, Shara worked in the detox unit at Maple Leaf Farm for 3 years. Once Shara became a nurse practitioner, she worked briefly at Maple Leaf and Brattleboro Retreat before landing at the Chittenden Clinic, Vermont's largest methadone clinic and hub. Shara quickly discovered the unique opportunities for engagement, motivation, and change when working with pregnant people with opioid use disorder. Shara has been an active member of Chittenden County's CHARM team, including presenting the model in Washington, D.C. to the new Governor's Institute in 2019. During the pandemic, Shara became passionate about understanding how secondary traumatic stress responses are impacting the healthcare workforce, her colleagues, friends, and herself. When not working, she's finding ways to enjoy being outdoors in every season of Vermont, including mud season. Hello and welcome, Shara.
Thanks, Jesse. You may hear pages turning. That's because I don't do technology very well. So I'll ask Jesse for the next slide, and then you'll hear pages turning. Before we go, yeah, perfect. We've got objectives. Before I go any further, if folks could put in the chat group, when you hear the topic, having difficult conversations, what's an example for you that pops up? I'm not going to type mine in right now because of that challenge with technology, but for me, it is the first thought that I come to mind is having conversations with DCF when I'm making phone calls and referrals. So the objectives, the purpose of this talk is to discuss challenges, stigma, have a better understanding of what might be happening for folks during these times when we have difficult conversations, emphasize why our strength-based approaches are again important in this, when we're looking at this theme. And hopefully I'm going to be giving you some little pearls that may help you in having difficult conversations. Next slide, please. So as I said, what are difficult conversations that you may encounter? For me, one of the main ones I said was DCF, making phone calls, contacts to DCF. We've got substance use, treatment navigation here. Great, I'm glad I'm on board since I'm pretty familiar with that part of it. Another one that I will share is the challenges when I am working with coworkers, colleagues, or perhaps even interacting with community members, team members who I don't work with as closely, when we have different models, approaches, ideas. In particular, I find it challenging when I feel like I am facing stigma or generally an attitude from colleagues and wanting to have a discussion on how to move forward with that. Perinatal mental health needs, talking with families around their choices, how it could affect their children, DCF reports, telling families about it, different approaches to care. Great. We all have similar things coming up when we're thinking about what are difficult conversations. Next slide, please. Anticipatory guidance when preparing yourself for difficult conversations is just critical. This anticipatory guidance, having an idea of what is coming, not just for you, but also for the clients that we are working with. I can't say enough about that. And I'll keep, this slide is one that I sort of summarized and came up with. You're going to see we're going to keep going through these things over and over again. The 3 Ps that I like to put in there, the knowing your policy, procedures, practices, this is critical. This is critical for you being able to understand, for you being able to present decisions and choices that you're making, consequences, be engaged in these conversations while also protecting yourself from them at the same time. then if we further that down, being part of a team, so crucial to us being able to do this work and remove the individual. I'm not the person doing this to other people. I'm part of a larger system. Those are my policies, procedures, and practices I'm following. I'm also part of a team. And then in this last slide, really, really important to know yourself and why do you do the work that you do, to make sure that you are doing it for the right reasons. When Amy and I were practicing yesterday, we were talking about how the work that we do gives us purpose, makes us feel like perhaps we're contributing to making a world a different place. We both noticed that we didn't say, we don't identify that we save lives, or it was much more of a meta purpose than that individual. Yes, we work one-on-one. Yes, we work intimately. But our role is to walk alongside people in their journey, to witness, to support, to guide. But that's our journey. That's our role. And I hope that some of you, are teasing that out as well and being really careful about what your role is. Why do you do the work that you do? Next slide. I do the work that I do because humans are amazing, and I have the opportunity of seeing people make incredible changes every day. So I've got a slide here of my heroin on the left, and or opiates, we can assume opioids. These days, folks tell me that they're using Percocet, and I'm suspecting that much of it is fentanyl pressed into Percocet-like tablets. And mine is Oreos. I am not in recovery. I do believe I can still do this work and be good at it without having experienced opioid dependence, withdrawal, maintenance, tapering off. I look to similar things in my life to try and find empathy, connection. So when I think about people I work with making a choice every day not to use heroin, and how difficult it is for me every day not to eat Oreos. It really is. Make a hard choice not to eat Oreos. But let's be realistic. My Oreos, my drug of choice, these are not going to cause me to have communicable diseases. If I choose to eat Oreos instead of eating an apple, DCF is not going to be contacted about my choices. If I can't afford my drug of choice, it is possible that assistance I get will purchase it for me, or I could donate blood and get a free pack of Oreos through there. I can drive safely while I'm eating Oreos if I need to eat my Oreos between one appointment and another as a coping skill. So again, I myself not in recovery, but I am in awe of the work that people do every day. There are days it's really hard not to eat a bag of Oreos. And that's nothing compared to the choices of the people that we're working with every day. I do this work because humans are amazing. I get to witness people making incredible change. When I started the work, I was pretty apprehensive about working with people who are pregnant, working in the perinatal arena. I quickly came to realize, as I said in that bio, in that introduction, how much this time of life is just phenomenal as far as being able to work with people when they are so motivated for change. They so badly want things to be different from the previous experience or to simply work out. Next slide. When we're working in this field, it is critical that we are cautious about the language that we use. We do not want to perpetuate stigma, judgment, general attitude that the people we are working with have faced throughout so much of their lives. We want to be a place where we can be supportive, where we can be free of judgment. So language, I feel like it's been touched on almost every seminar here. I can't say enough about being careful about the language that we use. The dirty, clean one, that's really important to me, that we're talking about urine drug screens that are positive or negative, or appropriate might be another word to use instead of that. It's important. These semantics matter, and language can contribute to perceptions of being judged. All right, ready for the next slide. How do we navigate these difficult conversations? This is, when I was asked to present this is, of course I do this. I have these conversations every day. Honestly, learning how to do this presentation was going back and finding some different models that fit with this. You're going to see repetition. There are some really common themes, but these are the models we'll move through. Next slide, please. The CDC learned the signs and act early. When I talked about the importance of that anticipatory guidance, this is really where this may start for folks who are working with children and families, that if you are starting with engagement and giving that the learn the signs, act early, giving the guidance, these are the milestones we're looking out for. If you keep talking about those ahead of time, then it's not playing catch up. Well, your child isn't doing this. Remember how we talked about when and by this age, we were thinking this might be happening. Well, this is what we're seeing. It's different from that. So the learning the signs, that's again, that part of that anticipatory guidance. Here again, we talk about how important it is to be highlighting the children's strengths, and that listening is really important. That strength-based motivation, one of the reasons it's so important to do it, again, it helps ameliorate any judgment or stigma folks might be feeling, but also success equals motivation. If we are highlighting strengths, we are also increasing motivation. Very important in there. Okay, speaking of motivation, next slide. We move into, next slide after this. This is sort of my slide set. Okay, motivational interviewing. I hope that most of us have heard of, have been trained of, right? We need full day trainings, lots of role playing just to do motivational interviewing. I will admit that in the moment of a difficult conversation, I don't find much place for motivational interviewing. MI is what I can use beforehand when I'm working with the anticipatory guidance, when I'm talking about things that I see are coming. That's where I can have the time to go back and take the time of the themes with MI to help people come to their own realizations, their own conclusions, identify their own goals instead of me telling them what they are. And honestly, as a nurse practitioner, I mentioned that teamwork makes dream work. I am part of a larger team. My office visits are set up for problem-focused visits, right? Sort of that SOAP note, subjective, objective, assessment, plan. That's the way that I'm trained. That's the way I'm set up. There are times where I might not be the most appropriate team member to really engage in motivational interviewing. Know your job, know your roles. Okay, next slide are keys to the concept of emotional interviewing, expressing empathy. Talk about how important empathy is in having difficult conversations. Empathy is the antidote to escalation. If you can demonstrate a true level of empathy, it's hard to do, but it can be done. And why do I say it's hard to do? Well, right here, the use of I understand statements. I can't tell you how many times I've started to say I understand, only to have a person throw that back in my face. No, you don't. Do you know what it's like to withdraw in a jail cell? Do you know what it's like to have your baby taken from you in the hospital room? No, you don't. And they might be right. I might not understand. So I hedge using just an I understand statement. I do use things like I hear you. I can imagine feeling the same way if I were experiencing what you are. I understand how you're feeling that way, or I understand why you're thinking, like why you have come to that conclusion. Those are the parts of that empathy and where I use that I understand statement. Next slide, please. We'll move into now the Spikes protocol of sharing bad news. And the Spikes protocol is something that was originally created by oncologists. Remember the C word when we didn't say cancer? Some of you may not be old enough. I didn't actually share that I am also a middle-aged white female wearing a white shirt with an orangish sweater over it with long brown hair with lots of silver streaks shooting through it. So I am old enough to remember when cancer was referred to as the C word. The Spikes protocol came out of oncologists trying to develop a better way of talking with folks about bad diagnoses. When I look at these and I think about how do these apply to having difficult conversations, I put out there that I'm not sure we have much opportunity for the I of this. So maybe we use fix when we're doing bad conversations, because often we don't have an opportunity to obtain the patient's invitation. Next slide, please. But again, in each of these protocols, these themes, these models I've chosen, there's really good things that we can draw out of it. With Spikes, the setting up the session is just critical. You've got to be grounded in the moment, you as the person leading the difficult conversation. Do you rehearse it? Have you ever sat in your client's chair? I mean, got away from your desk or wherever you are and sit in the chair that they sit in? Your office can look very, very different when you take it from a different point of view. That point of setting up the session, I think about that. I think about what does it look like? My chairs are behind me here, so I usually turn right around. And often in the afternoon when I meet with people in the office, I let them sit in my desk chair and I sit over there. This is with coworkers, so that I can see what it's like to sit in their place, setting up that session. And again, that part that I started with in setting up the session, making sure that you're being careful about being grounded in the moment. Next slide. We're working on a slightly different slide set. So asking the patient perception before participation. On this one here, I often start my sessions with what do I know? And this often is a review of what we've already talked about at our last session, but in a part of a way of helping people I'm working with trying to help them feel more comfortable with me. I want to demonstrate my transparency. So often this will happen for me in an intake or even in a follow-up session where, good to see you again. Haven't seen you for a while. Let me review the things that I know. This is what your dose is. This is how frequently you're getting it. This is what your most recent urine drug screens are. This is something I've noticed in the notes from a coworker, so that I am starting the perception, hopefully starting the perception, the participation in the setting of our conversation with showing that I'm not hiding things, that I'm sharing everything that I know. Next slide. We talked about how in the invitation, in the moment of having a difficult conversation, you can see where this might have been a little bit more suited for delivering a bad diagnosis. So we'll skip on to the next slide. And giving knowledge. One of the things also, I guess on the invitation, little pearl I want to throw out there is how we ask if people have other questions. There are ways that we can use just slightly different words that sort of truncate what we're asking. So what other questions do you have for me? Is what I rehearse in practice. What other questions do you have for me? What other questions do you have for me? Rather than do you have any other questions? Are there any other questions? What else? Just sort of opening it up. What other questions? What questions do you have for me? Okay, if we can go on to the next slide, we're going to get into the emotions and how we deal with emotions with this empathetic response. Notice that in the Spikes protocol, they encourage you to observe and name the emotion. I think one's got to be very careful about naming emotion. I think it's okay to name what you observe. The difference between, I can see that you were sad and I can see that you're crying. Sad is naming an emotion. We don't know if they're crying because they're sad. We only know that they're crying. So yes, we address the emotions. Yes, be connected. Yes, eye contact. Yes, model your calmness in this as well. This is difficult, but your calmness as well. Hopefully they can reflect some of that also. So I see you're crying. I know you didn't want this to happen. These are things that I use. In working with emotions, we're also working with the validations and validating, again, I sort of said it similarly before. I think I'd be feeling the same way if I was going through what you were going through. Or the other one that I use is other people I've worked with who've been in a similar situation have done X, Y, have done this. That other people I've worked with in a similar situation does a couple things. I hope that it increases some confidence in me that this isn't the first time I've dealt with this. I've been here before. We've done this before. I also hope that for the person I'm working with, maybe there's a little bit of normalization. They're not the only person that this has happened to. And then the strategy, the summary, next slide with that is wrapping it up. And one of the things that is really important to me in a difficult conversation, or really any conversation, in my wrap up, in my strategy, in my summary, my plan, is that I sort of bullet out what the plan is, what the next steps are. I also use my hands a lot when I talk. So I literally bullet out what the steps are, say that out loud. If I'm really on my game, I've typed that and I'm printing it and giving a copy to the person before they leave. The other reason that's me being on my game is those bullet points that I just reviewed and discussed. That's the end of my note. That's the end of my documentation. And when I do that and have that right away, I write my notes backwards, don't know about anybody else, but I tend to go right into my note and what was the plan? What are we doing for the next steps? Because that's where I pick up. That's also where I leave notes to myself, reminders to myself of things that I want to check in on. It also just, again, reinforces that we had a plan, that we're moving toward this. My goal is that when I am engaging in a difficult conversation, somebody's not blindsided by it, that we've been talking with that anticipatory guidance, with those milestones along the way. We've been talking about that this might happen. So then moving on from the spikes, next slide, please, is the pause solving framework. And pause comes from this book, Tackling the Tough Stuff by Tomlin and Vuhig, and published in 2016. The pause problem solving framework is one chapter out of this book. It's a home visitor's guide to supporting families at risk. I learned of this because of this chapter, which is pretty impressive. What I think a lot of you can take away from this in the next slide is that they come with handouts. Next slide, Jesse. Yeah, there we go. They come with handouts, this pause worksheet, that go over where pause summarizes, pulls everything in together, is that we're going to perceive, ask questions, understand the participants' experience or viewpoint, strategize, and evaluate. So everything that I've been talking about in facing a difficult conversation, like I said, even if we're using a different model, if we're using pause, but you really like the things that were in Spike, or actually there's big parts of MI, motivational interviewing, that you want to use in here, these worksheets still give you a place to include all of that and summarize all of that. So there's a worksheet to help you think about what's happening. And then next slide. Then there's also worksheets out of this chapter for you to reflect on how it went. Studying to do this presentation and finding these worksheets, I especially think that these will be useful for me when I'm having conversations with team members and we want to think about where we want to take a case, what our next steps might be in that case. Okay, next slide is the Harvard Law School program on negotiations. Some decent resources, some quick articles and blog posts to look at when thinking about conflict resolution. Here are the difficult conversations. They've happened or are happening. What are things for us to consider in them? Now, remember that this is written in the view of negotiations, where negotiations, right? Negotiating, some give and take, some back and forth. Often when we are having the difficult conversations that we're having, there's not a place for negotiation. But like I said, again, there are themes in here that are helpful and useful for us in thinking about recognizing we all have bias. You've got to continually challenge yourself for your implicit bias. To be able to do this work well, to protect yourself, you've got to be able to think about this. We have them. We all have them. Turn it on yourself. Examine yourself. Here's my example of my most recent challenge. Sometimes on the weekend, I really bad TV with my teenage daughter. There's this show called Love is Blind, a reality show. Did I mention it's really bad TV? So in this reality show, contestants meet each other, but they can't see each other. And through a series of conversations, they decide whether or not they want to get married. So we watched the whole first season. It was a great thing for us to do, to be fluffy and relax in the evening together. We started watching Love is Blind Japan. And wow, I have a lot of biases. I have a lot of internal ways that I put people in boxes. And when I'm watching a show like this that's in a completely different culture, I don't have my boxes anymore. And I couldn't even understand, we're reading subtitles. I'm not even sure that I understand the nuances of language, if somebody's being sarcastic or being funny, because I don't understand that language. But again, I can't turn it off. I'm always looking for where I am biased. If I ever hear myself say these people, oh my gosh, I just can't, these people, then I am burnt. Then these people to me is a sign that I have moved away from my open-mindedness and getting to a place of frustration. There's not creativity that's happening there. There's not support and advocacy that is happening there. For me, in my workday, again, these people, that's a huge, huge red flag for me and where I am in my day. You've got to avoid escalating tensions. This number 2 in the negotiation. I mentioned that a little bit back there about having empathy. I mentioned that about grounding yourself. Whatever the practice is that you do, when you're walking into a room, in particular, when you're preparing for a difficult conversation, you must be present only in that moment. You must turn off everything that was happening in the day beforehand, leading up to being in this room for this conversation. You must not be thinking about what's going to happen in the afterwards as well. You've got to be in that moment. This will absolutely avoid the escalating tensions. People know if you're distracted. Of course, there are times where I've brought stress, personal stress, work stress from another situation into the room with me. The session does not go as well. I do think one of the things that really helps me with the escalating tension is being born with the good grace of this sort of soothing voice. I also did a lot of acting in high school. Are there times I'm faking it till I make it? You bet. Are there times in my head that I'm thinking, now playing the role of nurse practitioner is Shara Charul? You bet. Yes. But that's what I need to do so that I'm not contributing to any escalation in any emotion. I am balanced. I am grounded. I can watch somebody have an impressive, strong reaction without also having an impressive, strong reaction. I think all of this leads and contributes to this number 3, overcoming the us versus them mentality. Looking beneath the surface to identify the deeper issues, this is where it is critical that we are aware of how trauma, how ACEs impact people today, past histories. Separating the sacred from the pseudo-sacred, that's also a really challenging part, but something that we have to honor, because we're not responsible for the change we're hoping to see. We are witnessing it. So if we have a difference in our sacred issues, then, oh well, we do. That's not our job. We have to witness and be along with that person. A brief example of a time where I was really challenged with this was working with a person who was undecided about their pregnancy, which was fine. They were heavily using heroin, fentanyl, methamphetamine, which also contained amphetamine, cocaine, more fentanyl in it. They were also testing positive for prescription medications like both gabapentin and pregabalin, so Neurontin and Lyrica. Heavy polysubstance use early in pregnancy. And as I was trying to engage this person, trying to check in with them, they continued to be undecided about continuing the pregnancy. As we were moving a little bit further along, they were beginning to talk more and more about how they cannot terminate. That is against their beliefs, their morals, their system. They cannot terminate. That is their sacred issue. What was really challenging for me was that as we were nearing really the end of being possible for termination, and I was sort of saying, setting up this difficult conversation, you have to come in and meet with me. I mean, talk about invitation. Things can get to a point here where I have to do what's called stop dose, where I say somebody can't get their dose of methadone or Suboxone until they meet with myself, a counselor, until they have that meeting. It's something that we really don't like to do very frequently. And just to be clear, if a person was pregnant, we wouldn't ever really stop them from getting their dose, but we can sort of put it in as a pause dose. Shara really wants to talk to you before we dose. What was hard for me is working with this person, they were getting to the point where it was too late to make a decision. And as we were having this conversation, they had said, yeah, I really hoped that, honestly, that I would use enough heroin that, you know, my body would take care of it. I wouldn't have to make the decision. It would just happen anyway. And there's so much that's conflicting and challenging about that. One of them being that if somebody really wanted to use a lot of drugs to try and abort, it would probably be better to use more of the stimulants than the opiates. So I didn't educate on that topic at that moment. But again, how challenging separating from the sacred to pseudo-sacred issues. I will admit that person is now postpartum without children in their custody, continuing to use. There's less of a place for me from the medical intervention right now because they are postpartum, stable on their dose. And this continues to be a challenging case for me to work with. But go back to number 1. How much clearer could I be about the biases, the challenges that I'm having working with this, that I've named them, that I talk to my coworkers about them? These are the things that allow me, when I am engaging with this person, to be present, to put everything back. As a nurse practitioner, I do have some times where I get to reduce people down to their physical bodies, their medicine, the sort of the medicine aspects of it. And in that, I find that I can continue to do the work and strive to do the work for this person at the same quality, at the same level as I do for everybody else, even though we have really some big differences in our sacred, what we call our sacred issues. Last slide, second to last slide, please. I summarize all of this by saying, in the work I do, I celebrate that I dance in the gray. For many of you who are working with children and families, you have to work in an abstinence-based system. That's pretty black and white. You're positive or you're negative. I don't. I absolutely work in harm reduction. As a methadone hub, we are considered one of the highest levels of outpatient care for people with opioid use disorder. We do not kick people out for ongoing use. We look for harm reduction, constantly looking for ways that we can improve as we are on our journey towards abstinence. Yes, abstinence is the goal. Of course it is. But that's not where we're starting. Where I'm starting with them is dancing in the gray. This dancing in the gray piece is also a part of being comfortable with being uncomfortable. That part of knowing my lane, knowing my job, knowing my role. I can't do more work than the individual that I am trying to support and guide. It's their work to do. There's some grayness in that. There's some grayness in being comfortable with what I can't control. And that's essential to being able to do this work well and being able to do this work for a very, very long time, which is what I intend to do. My last slide is references. You'll get slide sets, easy enough to just Google the CDC for those milestone tips, and also the tackling the tough stuff. I found this as well. So I can start with questions now, or we can move into the case presentation. So there we go.
Thank you so much, Shara. This is Jesse Suter. We've got a minute or two for questions for Shara right now. I didn't see anything in the chat, but feel free to type it in there or raise your virtual or real hand. Only one of you is on camera right now, so if it's anyone other than Alyssa, I won't be able to see you unless it's a virtual hand. Heather just wrote in chat, I could jump off for another meeting, but wanted to say how important it is for us to recognize our own biases. And thanks. Would you mind resharing links for spikes and pause? I think I can do that through the references. I'll just put that back on the screen. Give me just a moment. So Shara, the pause framework is from that book, Tackling the Tough Stuff. Is that right?
That is right, but you can also access the PDF of just that chapter. And so what we may find, Jesse, is at the end, I could send better links just to those chapters that could be sent out.
Great. I'm seeing a few other messages here. I'm curious, and now they're coming in. I am curious on how systems best work together when they have different goals, abstinence versus harm reduction.
Yeah. And Ashley and I get to work together with some of these as well. I think, first of all, the folks from the different systems being really clear on that. For example, DCF in Chittenden County, the CHARM team in Chittenden County, at Chittenden Clinic, we are not treating the unborn child. This is in pregnancy, and this refers to our CHARM meetings. We are not treating the unborn child. We are treating the pregnant adult. Our lawyer has carefully looked at the CARA, the CAPTA laws, and if there are not other children in the home that are meeting the criteria for mandated reporting, we do not report positive urine drug screens during pregnancy until the last 30 days. OBs and other people who are caring for the unborn child, they are reporting in the last trimester. So when we are working together, folks at the charm table, and we have this conversation at least once a year of where the different agencies' thresholds are or interpretations are. I mean, there's not a threshold for the law is the law. And so I think for me, it's really important to foster one-on-one relationships with people from other agencies that have differing approaches. This allows us at times to ask questions that aren't case specific, but are procedure specific. And so I do think it's really important that different agencies identify what are the philosophies behind the agency you're coming from? Where do we overlap? Where don't we? So that each agency is working with the other agency optimally, and not asking things that they can't do, or also being able to optimize that as well. It's a good question. I've got another question. I can read this here. When working with a family who has poly issues, mental health, substances, where processing information may be difficult, how do you follow up on those difficult conversations? Letters, notes, case notes. First of all, I do not have a difficult conversation if I suspect that somebody is in an altered state in that moment, including agitated from mental health, not from substances. But if mental health is too much, then I'm going to truncate everything down. This may be a session where if there's a consequence I have to follow through with, like I was hoping that we would make the phone call together to DCF to report that there'll be a positive in the last 30 days. That is what I try to do in general. But the person we've had that appointment, but now I'm on day 30 and they are not in a position to join me for that appointment. I still have to make it. And then, there's some catch up afterwards to explain. But because I've done my anticipatory guidance, because I've been clear about what my agency's policies and procedures were, this was not blindsided. They knew that this was coming, and that helps as well. But also don't only be looking, are people high, are they under the influence? Also recognize that people's mental health could be so exacerbated at a moment that that's not the time to have the conversation. Okay, thanks.
Great. This is Jesse, and thank you so much, Shara. We are going to need to move to the case presentation now, but thank you for agreeing to participate today. That was wonderful, and thank you everyone for your questions and engagement. So we'll look forward to, we'll add any new links or other information that you want to share. We'll put that with the handouts on our website.